Welcome to this video entitled, Opportunistic Infections in Liver and Intestinal Transplantation. Liver transplantation has been established as an effective treatment for children with end-stage liver disease for more than 30 years. Improving surgical techniques and the availability of new and more potent immunosuppressive regimens have led to enhanced survival rates, with 3-year survival rates approaching or exceeding 84%. In response to these excellent results, children with end-stage liver disease are routinely referred for liver transplantation, and increasing numbers of pediatric centers routinely perform this procedure. Intestinal transplantation, performed as an isolated procedure or in combination with the liver or other organs, has also gained expanded acceptance as a treatment for children with refractory intestinal failure, with steadily improving survival rates over time. This is particularly true for those children who experience progressive liver failure due to hyperalimentation-induced liver disease. Although this newer procedure has been routinely performed at a relatively limited number of centers, an increasing number of transplant programs are beginning to offer intestinal transplantation. Infectious complications have been a significant cause of morbidity and mortality in children undergoing liver transplantation since this procedure gained its initial acceptance in the 1980s. However, improvements in the treatment options for and management of immune suppression, along with the increasing availability of new antimicrobial agents and diagnostic tools, have resulted in reductions in the impact of infectious complications on these children. Intestinal transplantation is associated with many of the same infectious complications seen after liver transplantation, as well as a number of infectious issues that appear to be unique to this procedure. Although development of increasingly effective treatment strategies for infectious complications is of great benefit to the children undergoing these procedures, emphasis has increasingly shifted to the development of strategies aimed at the prevention of infectious complications in children undergoing abdominal transplantation. A general overview of the problem of infections after liver and intestinal transplantation in children is presented in this chapter. We will now discuss the predisposing factors. Liver and intestinal transplantation are associated with a set of technical and medical conditions that predispose to a unique set of infectious complications. The abdomen is a common site of infection in patients undergoing both of these procedures. This is almost certainly due to the occurrence of local ischemic injury and bleeding, as well as potential soil age with contaminated material. Additional factors predisposing to infection can be divided into those that exist before a transplant and those secondary to intraoperative and post-transplant activities. We will now switch gears to pre-transplant factors. The underlying illnesses leading to transplantation may be associated with intrinsic risk factors for infection. Some disorders may have required palliative surgery, which increases the technical difficulty of the transplant and may be associated with an enhanced risk for developing post-transplant infections. For example, children undergoing liver transplantation for biliary atresia may have previously undergone a Kasai procedure, choledochogionostomy, which may predispose to recurrent episodes of bacterial cholangitis before transplantation, increasing the likelihood of colonization with multidrug resistant (MDR) bacteria that can cause infection after transplantation. Similarly, children undergoing liver transplantation for cystic fibrosis may have an increased risk for developing invasive aspergillosis if they were colonized with this pathogen before transplantation. Complications of end-stage liver disease, as part of a primary liver disease or as a consequence of hyperalimentation in patients with intestinal insufficiency, may also predispose to infection after a transplant. A history of one or more episodes of spontaneous bacterial peritonitis before transplantation in patients with ascites has been associated with an increased rate of bacterial infections after liver transplantation and could occur in patients with liver disease associated with intestinal insufficiency. Finally, children awaiting intestinal transplantation experience frequent episodes of gastrointestinal-associated bloodstream infections. Recurrent exposure to antimicrobial agents to treat these episodes of bacteremia increases the likelihood of colonization and disease with MDR bacterial and fungal pathogens after transplantation. Risks for bacterial translocation after intestinal transplantation with resultant bloodstream infection include the presence of a colon graft, 18 hospitalization before transplantation, and treatment with mycophenolate mofetil, abbreviated as MMF. Age, another important pre-transplant factor, is a major determinant of susceptibility to certain pathogens, severity of expression of infection, and immune maturation. Young children undergoing abdominal transplantation may experience moderate to severe infection with certain viral, e.g., respiratory syncytial virus, abbreviated as RSV, or bacterial, coagulase-negative staphylococci, pathogens compared with more mild illness experienced by adult recipients infected with these pathogens. In contrast, certain pathogens, such as Cryptococcus neoformans, uncommonly manifest infection before young adulthood. Age is also an important factor governing clinical expression of infection with cytomegalovirus, abbreviated as CMV, and Epstein-Barr virus, abbreviated as EBV. When transplants are performed in young patients, there is a high likelihood that they will be seronegative for CMV and EBV and therefore susceptible to primary infections, which are more severe than infections due to reactivation. Donor-related issues represent another set of pre-transplant factors. Transplant recipients are at risk for acquiring infections that may be active or latent within the donor at the time of organ harvesting. The most common examples of donor-associated infections are CMV and EBV. Infections caused by CMV and EBV have been more severe after intestinal transplant compared with other organs. This may be because the intestine is an organ rich in lymphoid tissue, which may result in bringing a larger viral load of viruses from the donor compared with other graft types. Similarly, adenovirus has been isolated more commonly from pediatric recipients of intestinal transplants compared with other organs, which may also be related to donor transmission in the accompanying lymphoid tissue. In contrast to CMV and EBV, for which donor-derived transmission is expected, increasing attention has focused on the unexpected transmission of other pathogens such as human immunodeficiency virus, HIV, hepatitis B virus, HBV, and hepatitis C virus, HCV. Although the systematic use of donor screening has led to a decreased frequency of unexpected transmission of HIV, HBV, and HCV, evidence demonstrates donor-associated transmission of West Nile virus and rabies, as well as a number of other uncommonly transmitted pathogens. Because organs from a single donor often go to disparate sites, it is important for the recipient center to report back to the United Network for Organ Sharing, abbreviated as UNOS, any unusual infections that might possibly have come from the donor. We will now discuss intraoperative factors. Operative factors unique to liver transplantation may predispose to infectious complications. For example, liver transplant recipients undergoing Roux-en-Y choledochoduodenostomy experience more infectious episodes than do those who undergo a choledochocolidocostomy with T-tube drainage. However, only the former option is usually performed in children undergoing liver transplantation because of the small size of their bile ducts. For combined liver-intestinal transplantation, evolution to en-bloc replacement of the liver and intestine avoids the need for additional biliary anastomosis and minimizes the risk for infection related to biliary complications. Prolonged operative time, that is longer than 12 hours, during the initial transplant has been associated with an increased risk for infection after transplant and is likely a surrogate marker for the technical difficulty of the surgery. Intraoperative events, such as contamination of the operative field, also predispose to postoperative infections. Finally, the inability to close the abdomen after the transplantation due to size discrepancy or intraoperative complications appears to increase the risk for postoperative infections. Next we will discuss post-transplant factors. Technical problems, immunosuppression, presence of indwelling cannulas, and nosocomial exposures are major postoperative risk factors for infectious complications. Thrombosis of the hepatic artery is the most serious technical problem after liver transplantation and predisposes to areas of necrotic liver and development of hepatic abscesses and bacteremia. Bile duct strictures, developing as a sequelae of thrombosed hepatic artery and ischemia or due to technical difficulties, may predispose to cholangitis. Retransplantation represents a high risk for intra-abdominal infection after intestinal transplantation. Immunosuppression is the critical postoperative factor predisposing to infection in all transplant recipients. Immunosuppressive regimens have evolved in an attempt to achieve more specific control of rejection with the least impairment of immunity. Thus, this evolution is aimed not only at improved control of rejection, but also at decreased morbidity and mortality from infections. The use of cyclosporine-based regimens resulted in a decreased incidence of infections in renal and cardiac transplant recipients. The introduction of tacrolimus has allowed many patients to be managed without corticosteroids. Although reported rates of infection have been similar in liver transplant recipients treated with tacrolimus compared with those receiving cyclosporine, an apparent decrease in morbidity and mortality, especially from viral pathogens, was noted with tacrolimus. In contrast to these results, some centers reported an increased rate of EBV-associated post-transplant lymphoproliferative disease, abbreviated as PTLD, in patients receiving tacrolimus. However, data from the University of Pittsburgh suggest that the short and long-term incidence of EBV-associated post-transplant lymphoproliferative disease appears to be similar in pediatric liver transplant recipients treated with either cyclosporine or tacrolimus. More recently, induction immunotherapy has been used in combination with corticosteroid-free or corticosteroid-sparing immunosuppressive regimens, and newer agents also are being explored. Potential infectious risks will need to be assessed for these and other evolving immunosuppressive regimens. Children undergoing intestinal transplantation require an increased baseline level of immunosuppression compared with patients undergoing most other solid organ transplant procedures. With this increased level of immunosuppression has come an increased risk for development of infection. In an effort to overcome this, a number of alternative immunosuppressive strategies have been explored. Looking at one such alternative strategy, Loynaz and colleagues found an increased risk for bacterial infections with both mycophenolate mofetil and daclizumab after intestinal transplantation. Another alternative approach evaluated the use of alemtuzumab induction in pediatric intestinal transplant recipients, and this was associated with a marked increased incidence of EBV-associated post-transplantation lymphoproliferative disorders in one study but not another. The treatment of rejection with additional or higher doses of immunosuppressant agents increases the risk for invasive and potentially fatal infection. Of particular concern is the use of anti-lymphocyte preparations, which are often indispensable in the management of corticosteroid-resistant rejection. The prolonged use of indwelling cannulas at any site is an important cause of infection throughout the postoperative course. The presence of central venous catheters is a cause of bacteremia after transplantation. This is particularly important for children undergoing intestinal transplantation, where maintenance of long-term central venous access has been required for prolonged periods of time after transplantation. The development of urinary tract infections and bacterial pneumonia are associated with the use of urethral catheters and prolonged nasotracheal or endotracheal intubation, respectively. Nosocomial exposures constitute the final group of postoperative risk factors in the hospital setting. Transplant recipients, especially children, may be exposed to many common viral pathogens, e.g., rotavirus, RSV, or influenza, while hospitalized. The presence of resistant bacteria in the hospital increases the risk for nosocomial transmission and disease. Attention to infection control policies aimed at local epidemiology of circulating infections is paramount. Finally, the presence in the hospital of heavy areas of contamination with pathogenic fungi, such as Aspergillus, may increase the risk for invasive fungal disease in these patients. The rate of fungal colonization increases during times of hospital construction. Infection control policies aimed at local epidemiology of circulating infections is paramount. We will now discuss timing of infections. The time of onset of infection with various pathogens after transplantation tends to be predictable. The majority of clinically important infections occur within the first 180 days after transplantation, although infections continue to occur quite frequently beyond this time after intestinal transplantation. The timing of infections can be divided into three intervals. Early, that is 0 to 30 days after transplantation. Intermediate, that is 30 to 180 days after transplantation. And late, that is beyond 180 days after transplantation. In addition, some infections may occur throughout the postoperative course. These divisions should be viewed with flexibility because they may be modified by prophylaxis strategies and are somewhat less applicable to recipients of intestinal transplantation. Despite this, they remain useful, giving a general approach to a patient with fever after transplantation, and can be used as a guide to differential diagnosis. An overview of the infectious complications occurring during each of these time periods is provided in tables 72.1 to 72.3 and is summarized in the following sections. We will now focus on early infections, that is 0 to 30 days. Early infections, as shown in table 72.1, tend to be associated with pre-existing conditions and surgical manipulation. In general, they are caused by either bacteria or yeast. Bacterial infections are particularly common after intestinal transplantation, being reported in up to 90% of recipients. As many as half of these early infectious complications may develop in the first 2 weeks after abdominal transplantation. Cholangitis or spontaneous bacterial peritonitis presenting at or near the time of liver transplantation may lead to intra-abdominal infection after the transplant. Technical difficulties, e.g., thrombosis of the hepatic artery or portal vein and biliary strictures, predispose to early bacterial infections. Likewise, development of bile leaks and bowel perforations are associated with polymicrobial intra-abdominal infections, primarily consisting of enteric bacteria and candida species, in the first month after transplantation. Early bacteremia is exceptionally common in intestinal transplant recipients and is usually associated with the presence of central venous catheters. Likewise, early bacteremia with gram-negative pathogens in these children has been associated with intestinal rejection. Re-exploration of the abdomen is associated with increased rates of fungal infection. Finally, herpes simplex infection can also reactivate and cause early symptomatic disease, although this is uncommon in children. Pause the video and carefully scrutinize Table 72.1 Differential diagnosis of infectious complications during the early period, that is 0 to 30 days, after pediatric liver and intestinal transplantation before advancing to the next slide. Pause the video and carefully scrutinize Table 72.1 Differential diagnosis of infectious complications during the early period, that is 0 to 30 days, after pediatric liver and intestinal transplantation before advancing to the next slide. Next we will discuss the intermediate period, that is 31 to 180 days. The intermediate period, as shown in Table 72.2, is the typical time of onset of infections associated with non-bacterial donor-associated transmission, either organ or blood products, reactivated viruses, and opportunistic infections. CMV peaks in incidence during this time. However, the use of prophylaxis against CMV can modify the time of presentation so that the occurrence of disease from these organisms may be after 180 days. The intermediate period is also when many patients begin to present with EBV disease, including post-transplantation lymphoproliferative disorders and pneumocystis jirovecii pneumonia. Finally, bacteremia continues to be a frequent occurrence in pediatric intestinal transplant recipients, with as many as 50% of all bloodstream infections occurring in this population being identified in this time period. And now we will focus on the late infections, that is greater than 180 days after transplant. Late infections, as shown in Table 72.3, after abdominal transplantation are less well characterized than other periods because patients have usually been discharged from the transplant center to their respective homes, which often are quite far away. This makes the accurate accumulation of data on these late infections difficult. Nonetheless, problems such as recurrent episodes of bacterial cholangitis in liver transplant recipients, typically associated with underlying problems of the biliary tree, and bacteremia associated with ongoing requirement for a central venous catheter, intestinal graft rejection, and/or post-transplantation lymphoproliferative disorders in intestinal transplant recipients, continue to occur in this time period. In addition, children who are at high risk for CMV infection and have been kept on prolonged or recurrent courses of prophylaxis may develop late-onset CMV infection in the late period. We will now focus on infections occurring throughout the postoperative course. Iatrogenic factors are an important cause of bacterial and fungal infections at all times but predominate in the early transplant period. Central venous lines are maintained for a variable time. The risk for infection persists for the entire period that the catheter remains in place. This is a particularly important problem for recipients of intestinal transplants who frequently require central line access for prolonged periods of time. Similarly, the presence of urethral catheters and endotracheal tubes increases the risk for infections whenever they are in use. Nosocomial acquisition of community viruses, such as RSV, rotavirus, and influenza A or B can occur at any time after transplant. These viruses spread easily in hospital environments from personnel or other hospitalized patients to transplant recipients. It is therefore important to modify diagnostic considerations according to local epidemiologic considerations. Pause the video and carefully scrutinize Table 72.2 summarizing the differential diagnosis of infectious complications during the intermediate period, that is 31 to 180 days, after pediatric liver and intestinal transplantation before advancing to the next slide. Pause the video and carefully scrutinize Table 72.2 summarizing the differential diagnosis of infectious complications during the intermediate period, that is 31 to 180 days, after pediatric liver and intestinal transplantation before advancing to the next slide. Pause the video and carefully scrutinize Table 72.3 summarizing the differential diagnosis of infectious complications during the late period, that is beyond 180 days, after pediatric liver and intestinal transplantation before advancing to the next slide. We will now progress to bacterial and fungal infections. Bacterial and fungal pathogens are important causes of morbidity and occasional mortality in children undergoing liver and/or intestinal transplantation. With the exception of infections related to the use of indwelling catheters, sites of bacterial infection tend to occur at or near the transplanted organ. Accordingly, the intra-abdominal space is an important site of infection after any of the abdominal transplant procedures. Adding to the complexity of the management of bacterial infections in children undergoing abdominal transplantation is the fact that recovery of multi-drug resistant bacteria is increasingly common. Outbreaks of colonization and disease due to vancomycin-resistant Enterococcus fischum extended-spectrum beta-lactamus, abbreviated as ESBL, producing Klebsiella pneumoniae, and carbapenem-resistant Enterobacteriaceae have been reported among pediatric liver and intestinal transplant recipients. These multi-drug-resistant bacteria have been transmitted from patient to patient, prompting the need for close attention to and strict compliance with infection control procedures. In some cases, effective antimicrobial agents may be unavailable to treat these complications. Knowledge of results of previous cultures and antimicrobial resistance patterns locally as well as from the home institution of the patient are critical components in choosing initial empirical antibiotic therapy for these patients to maximize their outcomes. We will now discuss liver transplantation. Bacterial and fungal infections are a common early problem after liver transplantation. Rates for bacterial infection of 40% to 70% have been reported from multiple series. A 2008 review of the split registry for children undergoing liver transplantation between 1995 and 2006 found that around 33% of pediatric liver recipients experienced a bacterial infection, with the vast majority of these presenting in the first 30 days after transplant. Similar rates have been reported following living donor liver transplantation in children. Bacteremia often occurs in association with intra-abdominal infection or with use of central venous catheters, but it can occur without an obvious source. Enteric gram-negative organisms account for more than 1/2 of episodes. Bacterial infections involving the abdomen or surgical wound are common in most series. Infectious complications of the transplanted liver also occur. The most important complication is hepatic abscess associated with hepatic artery or portal vein thrombosis, which can be accompanied by persistent bacteremia. However, the introduction of frequent surveillance Doppler studies early after transplant to monitor for development of thrombosis, coupled with the use of operative thrombectomy and thrombolysis, have markedly diminished the development of hepatic abscesses in this population. Ascending cholangitis is relatively common after liver transplantation, accounting for 7% of infections in the split series and usually associated with biliary abnormalities. This diagnosis typically is made on clinical grounds in a patient with fever and biochemical evidence of biliary inflammation. Enteric gram-negative bacteria and enterococcal species predominate. However, this clinical picture can be identical to that of acute graft rejection. Liver biopsy should be performed to differentiate these processes. A cholangiogram is performed to assess the status of the biliary tract for patients with proven cholangitis. Historically, as many as 40% of children undergoing liver transplantation developed a fungal infection during the first year following this procedure, with Candida species being the most common fungal pathogen and infection usually being associated with an intra-abdominal focus or indwelling catheter. Infections due to Candida species have been most commonly recognized in the first month after transplantation, with candidal peritonitis most likely presenting in the first 2 weeks after liver transplantation in association with a bile leak or bowel perforation. The recovery of Candida from a Jackson-Pratt drain in the early postoperative period may be the first indication of either of these two technical complications, and may occur before the onset of clinical symptoms of intra-abdominal infection. Accordingly, recovery of Candida, alone or in combination with enteric bacteria, should prompt initiation of antimicrobial therapy and an aggressive evaluation for the presence of these complications. However, rates of invasive candidiasis have markedly declined, as demonstrated by a recent study of pediatric liver transplant recipients at 2 different centers that found that only 2.5% of 397 children developed invasive candidiasis in the first month following transplantation, as compared to a rate of 21% documented in an older study evaluating invasive candidiasis during the first month post-transplant. Candidemia accounted for 80% of episodes of invasive candidiasis in the recent series, with the only identified risk factor associated with the development of candidal infection being ICU admission in the 2 weeks prior to transplant. Historically, additional risk factors for fungal infection have included prolonged duration of intubation after transplant, hepatic artery thrombosis, volume of blood transfused, and exposure to corticosteroids within the 3 months before the transplant. Early initiation of antifungal treatment is particularly important, given an attributable mortality rate of up to 33% for candidal infections in pediatric liver transplant recipients in older literature. The availability of fluconazole and echinocandin antifungal agents, e.g., caspofungin, micafungin, and anadulafungin, increases the number of therapeutic options for the treatment of candidal infections. However, acquired or inherent resistance to the azoles is an increasing concern, as are drug-drug interactions between azoles with both cyclosporine and tacrolimus and echinocandins with cyclosporine. Episodes of invasive aspergillosis among pediatric liver transplant recipients are uncommon, but can be fatal. Infections due to other invasive molds are rarely seen. However, children undergoing liver transplantation for cystic fibrosis, abbreviated as CF, are at particular risk for developing infection due to Aspergillus and other fungi seen in children with cystic fibrosis lung disease. Early disseminated aspergillosis in children with cystic fibrosis undergoing liver transplantation at Children's Hospital of Pittsburgh of UPMC, CHP, was observed in the early era of transplantation, prompting the use of perioperative antifungal prophylaxis in liver recipients with cystic fibrosis and a history of recovery of aspergillus before transplant. Because data defining the precise duration of prophylaxis necessary to protect against this complication are not available, prophylactic treatment has ranged from 1 month of intravenous amphotericin to prolonged use of an oral azole agent, e.g., itraconazole or voriconazole. The availability of newer antifungal agents, including the advanced generation azoles, such as voriconazole and posaconazole, as well as the echinocandins, has increased the number and complexity of therapeutic options for treatment of aspergillosis in children undergoing liver transplantation. A summary of a suggested approach to the diagnosis and management of fungal infections after liver transplantation in children is provided in Table 72.4. We will now discuss intestinal transplantation. Although increasing, the numbers of children having undergone intestinal transplantation remain relatively small. Many have received combined liver and intestine or multivisceral transplants. Bacterial infection occurs frequently in these patients. One series reported that as many as 92% of children undergoing intestinal transplantation experienced an average of 2.9 episodes of bacterial infection per patient. More than 80% of these patients experienced their first bacterial infection during the first 2 months after transplant. Bacteremia, which can be explained in part by disruption of the mucosal barrier associated with harvest injury or intestinal allograft rejection, is a common finding, with one center reporting that 69% of pediatric intestinal transplant recipients experienced at least one episode of bloodstream infection. Coagulase-negative staphylococci, enterococci, and gram-negative enteric bacilli account for most episodes. As noted earlier, antibiotic resistance is commonly seen in recovered pathogens. In the CHP experience, episodes of gut-associated bacteremia frequently secondarily infect central venous catheters, producing persistent positive cultures even after resolution of clinical symptoms. Accordingly, treatment strategies aimed at preserving the catheter, e.g., antibiotic lock therapy, may need to be used in combination with systemic antibiotics to accomplish a sustained clinical cure. Intra-abdominal and wound infections also are seen commonly in this population, occurring in more than 1/3 of patients, and are typically detected during the first month after transplantation. Gram-negative enteric pathogens, which frequently demonstrate multiple antibiotic resistance as well as enterococci, often exhibiting vancomycin resistance, are the most common organisms associated with these complications. Recurrent laparotomies have been identified as a risk factor for intra-abdominal infection. One unique aspect of intestinal transplantation is the potential inability to achieve abdominal wall closure. Although failure to close the abdominal wall is an obvious risk for the development of intra-abdominal infection, the use of abdominal mesh as part of efforts to resolve difficult abdominal wall closures has also been associated with the development of superficial and deep wound infection. Another important site of infection is the intestine itself. Clostridioides difficile enteritis can present with fever, abdominal pain, and diarrhea that can easily be mistaken for graft rejection or viral infection due to CMV, EBV, and adenovirus. Accordingly, the diagnosis of Clostridioides difficile enteritis must be considered in any child in whom fever and changes in stool output are noted. In one small series, Clostridioides difficile enteritis was diagnosed in nearly 10% of children undergoing intestinal transplantation. The frequent exposure to antibiotics and prolonged hospital stays that children undergoing intestinal transplantation experience are major risk factors for the development of this complication. Standard treatment with oral metronidazole is the recommended first-line therapy. However, use of oral vancomycin, including prolonged tapered courses, or alternate therapies such fidaxomicin might be necessary for patients who experience relapse or recurrent episodes after primary treatment. Invasive candidiasis and candidemia occur relatively frequently after intestinal transplantation in children, with one center reporting an incidence of approximately 23% in a series of 98 pediatric intestinal transplant recipients. Candidemia accounted for 50% of the episodes of infection in this series, whereas nearly 40% involved the intra-abdominal space. Although the majority of episodes of candidemia infection occur in the first 3 to 6 months after transplant, later episodes may occur. Intra-abdominal infection with Candida frequently present as part of a polymicrobial infection related to technical problems occurring during the initial transplant surgery or subsequent laparotomies. Specific risk factors associated with invasive candidiasis and candidemia include ongoing requirement for total parenteral nutrition and antibiotic treatment in the 7 days before diagnosis. Invasive mycoses due to fungal pathogens other than Candida are rarely observed. A recent report on fungal infections from the University of Nebraska identified 4 cases of invasive aspergillosis in 98 children undergoing intestinal transplantation, whereas our experience at CHP has identified rare infections with Aspergillus, Alternaria, and Pseudosporium in this population. In general, these children have been on high levels of immune suppression or have other complications such as post-transplantation lymphoproliferative disorders, and outcome of these infections has been poor. Guidelines for the diagnosis and management of fungal infection in children undergoing intestinal transplantation are provided in Table 72.4. Pause the video and carefully scrutinize Table 72.4 summarizing an overview of diagnosis and management of fungal infections after liver and intestinal transplantation in children before advancing to the next slide. Pause the video and carefully scrutinize Table 72.4 summarizing an overview of diagnosis and management of fungal infections after liver and intestinal transplantation in children before advancing to the next slide. We will now progress to viral infections. Viral pathogens, especially herpes viruses, are a major source of morbidity and mortality after solid organ transplantation. Patterns of disease associated with individual viral pathogens generally are similar among all transplant recipients. However, frequency, mode of presentation, and relative severity can differ according to the type of organ transplanted and the serologic status of the recipient. We will now discuss cytomegalovirus. Cytomegalovirus continues to be the most common and one of the most important viral pathogens after organ transplantation in children. Cytomegalovirus infection can be asymptomatic or symptomatic and may be due to primary infection, either from the donor graft or blood products, reactivation of latent infection, or infection with a different cytomegalovirus strain in a previously seropositive child. Prior to the use of prophylaxis, the incidence of symptomatic cytomegalovirus infection was reported to be as high as 40% in pediatric liver transplant recipients. Use of Gan-C-Clavir prophylaxis or viral monitoring to inform preemptive treatment has resulted in a decreased rate and severity of cytomegalovirus disease. Intestinal transplantation was introduced after the availability of Gan-C-Clavir and therefore has been able to take advantage of using Gan-C-Clavir both as prophylaxis and treatment. Despite this, it is clear that cytomegalovirus disease can be very severe after intestinal transplantation and may have a high rate of recurrence. More recent reports identified decreased incidence and severity of cytomegalovirus disease in this population, although, compared to cytomegalovirus after other organ transplants, these patients continued to experience high recurrence rates of cytomegalovirus infection, more severe disease, and high rates of resistance. Primary cytomegalovirus infection, typically acquired from the donor organ, or passenger donor leukocytes that accompany the organ, is associated with the greatest degree of morbidity and mortality. Accordingly, cytomegalovirus seronegative recipients of organs from cytomegalovirus seropositive donors are considered at high risk for developing cytomegalovirus disease. Reactivation of or infection with a new strain of cytomegalovirus tends to result in milder illness after liver transplantation, but can still be severe after intestinal transplantation. Cytomegalovirus disease appears more likely to develop in cytomegalovirus seropositive recipients of cytomegalovirus seropositive donors than in seropositive recipients of seronegative donors. Patients treated with unusually high doses of immunosuppressants, especially anti-lymphocyte antibody preparations, experience an increased rate of cytomegalovirus disease regardless of previous immunity. Symptomatic cytomegalovirus disease classically presented between 1 and 3 months after transplantation. It is important to note that the use of prophylactic or preemptive monitoring regimens may delay onset of cytomegalovirus disease. When present, a characteristic constellation of fever, which may be high-grade, prolonged, and hectic, and hematologic abnormalities, including leukopenia, atypical lymphocytosis, and thrombocytopenia, is frequently seen. This cytomegalovirus syndrome occurs in 25% to 50% of patients with symptomatic cytomegalovirus infection. Invasive cytomegalovirus disease is manifest by visceral organ involvement. Common sites include the gastrointestinal tract, liver, and lungs. Cytomegalovirus hepatitis appears to be the most common site among liver transplant recipients, whereas cytomegalovirus enteritis is a frequent finding among intestinal transplant recipients. Cytomegalovirus chorioretinitis is rare in organ transplant recipients. Diagnosis of cytomegalovirus disease may be confirmed by detecting the presence of cytomegalovirus DNA or pp65 antigen in the blood of a patient with a compatible clinical syndrome. The pp65 antigenemia assay is less frequently used in recent years as nucleic acid test, abbreviated as NAT. Assays have become more widely available. Clinicians must be aware that results of viral cultures of the urine, bronchoalveolar lavage specimens, or even a positive blood test for cytomegalovirus by nucleic acid test or pp65 antigen, are difficult to interpret in previously infected patients because cytomegalovirus is identified in these sites in the absence of clinical disease. Serial evaluation of quantitative determinations of the pp65 antigen or cytomegalovirus DNA may add to specificity, but histologic examination of involved organs to confirm the presence of cytomegalovirus remains the gold standard when the diagnosis of invasive cytomegalovirus is being entertained. Antiviral agents with activity against cytomegalovirus, e.g., Gan-C-Clavir, Foscarnet, and C-dofovir, have improved the survival of transplant recipients with cytomegalovirus disease. Fatal disseminated cytomegalovirus disease occurred in 19% of infected children and 5% of infected adults undergoing liver transplantation in the era before ganciclovir was introduced. For clinical cytomegalovirus disease, ganciclovir therapy is given in conjunction with reduction of immunosuppression unless evidence of rejection is present. Clinical response usually occurs 5 to 7 days after initiation of therapy. Baseline immunosuppression levels are typically restored at the time of initial clinical response or on recognition of rejection. Data support the use of serial monitoring of cytomegalovirus load in the peripheral blood as a guide to initiation of and duration of cytomegalovirus therapy. Valganciclovir was equally efficacious in treating adult kidney transplant recipients with cytomegalovirus disease, but not those who had undergone liver transplantation. Controlled studies in children are lacking, but many centers use valganciclovir in children once they are discharged from the hospital. The role of cytomegalovirus hyperimmune globulin in combination with ganciclovir in the treatment of cytomegalovirus disease is controversial, although some evidence for improved outcome has been reported in the treatment of cytomegalovirus pneumonia in adult liver transplant recipients. Finally, because of the relatively high rates of nephrotoxicity associated with their use, Foscarnet or C-dofovir should be restricted to patients with apparent or proven resistance to ganciclovir, which should be suspected in patients who either fail to clinically improve or have persistent or rising cytomegalovirus viral loads after 2 weeks of ganciclovir therapy. Historically, approximately 25% of patients treated with ganciclovir for an initial episode of symptomatic cytomegalovirus will develop 1 or more episodes of recurrent cytomegalovirus disease, although rates of recurrent disease may have fallen in the presence of longer initial treatment and the use of secondary prophylaxis. When present, recurrences are observed about 1 month after the initial infectious episode and may be associated with invasive disease. More commonly, however, these recurrent episodes tend to be milder than the initial episode. Factors identified with an increased risk for developing recurrent cytomegalovirus disease include being a cytomegalovirus seronegative recipient of a cytomegalovirus seropositive donor, having disseminated cytomegalovirus disease, and having a history of multiple treatment courses for rejection and persistent elevations of the cytomegalovirus load at the end of therapy. Although current guidelines recommend continuing antiviral therapy until the cytomegalovirus viral load becomes negative, further research is needed on duration. A summary of our suggested approach to the diagnosis and management of cytomegalovirus infection is provided in Table 72.5. We will now progress to Epstein-Barr virus. Epstein-Barr virus infection, including Epstein-Barr virus-associated post-transplantation lymphoproliferative disorders, is an important cause of morbidity and mortality after liver transplantation and intestinal transplantation. This is particularly true among children undergoing intestinal transplantation, who experience higher rates of Epstein-Barr virus-related disease than any of the other organ transplant recipients. Symptomatic Epstein-Barr virus infection in general and post-transplantation lymphoproliferative disorders in particular most commonly occur among transplant recipients experiencing primary Epstein-Barr virus infection, particularly those who receive organs from seropositive donors. Accordingly, children undergoing transplantation are disproportionately affected by Epstein-Barr virus compared with their adult counterparts. As many as 80% of children who are Epstein-Barr virus seronegative before liver transplantation will develop a primary Epstein-Barr virus infection after this procedure. Although primary infection occurs in the vast majority of seronegative patients, clinical disease develops in less than 1/3 of these children. In one study, 4% of children undergoing solid organ transplantation and 10% of children with primary Epstein-Barr virus infection developed post-transplantation lymphoproliferative disorders between 1 month and 5 years after transplant. 75% of cases occurred during the first postoperative year in patients undergoing cyclosporine-based immune suppression. Historically, cumulative occurrence rates reached as high as 12% to 20% by 7 to 12 years after pediatric liver transplantation. Current rates of post-transplantation lymphoproliferative disorders in this cohort appear lower, with an incidence of 4.4% at 5 years after liver transplant for recipients who were Epstein-Barr virus seronegative prior to the procedure, likely owing to improvements in immune suppression and the use of preventive monitoring strategies. Pediatric recipients of intestinal transplantation appear to behave differently than children undergoing other types of organ transplantation in that the rate of Epstein-Barr virus disease, including post-transplantation lymphoproliferative disorders, occurs irrespective of Epstein-Barr virus serostatus before transplantation. Rates of Epstein-Barr virus disease and post-transplantation lymphoproliferative disorders after intestinal transplantation as high as 30% to 40% were reported during the initial experiences with intestinal transplantation. More recently, these rates have declined to approximately 11%, reflecting improved immune suppression regimens and Epstein-Barr virus monitoring protocols. However, these rates still remain higher than those seen among other organ recipients. A wide spectrum of Epstein-Barr virus disease is recognized that includes nonspecific viral illness, mononucleosis, and post-transplantation lymphoproliferative disorders, including lymphoma. Histologic evaluation is important in differentiating among these categories. Manifestations can evolve in individual patients. Asymptomatic seroconversion also occurs. Variation in severity and extent of disease is related to the degree of immunosuppression and adequacy of the host immune response. Although Epstein-Barr virus disease and post-transplantation lymphoproliferative disorders may present as involvement of many different clinical sites, there is a tendency for Epstein-Barr virus disease to involve the transplanted organ. Thus, Epstein-Barr virus hepatitis and post-transplantation lymphoproliferative disorders of the liver are observed more commonly among liver transplant recipients. Similarly, the intestine is the most frequently observed site of involvement of Epstein-Barr virus disease among intestinal transplant recipients. Of interest, involvement of sites beyond the gastrointestinal tract is uncommon in intestinal transplant recipients. Onset of viral syndrome, mononucleosis, and post-transplantation lymphoproliferative disorders occur primarily within the first year, whereas lymphoma tends to present later. Immunosuppressive regimens based on the use of tacrolimus appear to have affected a shift in the timing of post-transplantation lymphoproliferative disorders. Only rare cases occur later than 18 months after liver transplant, although late cases are more likely to occur after intestinal transplantation. The impact of newer immunosuppressive agents and regimens on Epstein-Barr virus disease needs to be constantly re-evaluated because unexpectedly high rates of post-transplantation lymphoproliferative disorders have occurred with some new regimens. The diagnosis of Epstein-Barr virus-associated post-transplantation lymphoproliferative disorders is made on the basis of clinical, laboratory, and histopathologic examination, and should be suspected in patients with protracted fever, exudative tonsillitis, lymphadenopathy, organomegaly, leukopenia, or atypical lymphocytosis. Gastrointestinal involvement should be suspected in patients with persistent fever and diarrhea. Accordingly, Epstein-Barr virus must be considered in the differential diagnosis of rejection among intestinal transplant recipients. Serologic diagnosis is often confounded by the presence of passive antibody acquired at the time of transplantation or during subsequent transfusions. The detection of increased Epstein-Barr virus viral load in peripheral blood identified by PCR has gained wide acceptance as an assay to predict risk for or presence of Epstein-Barr virus or post-transplantation lymphoproliferative disorders. Although extremely sensitive, these assays are limited by both a lack of uniformity across different laboratories and their lack of specificity. They are often elevated in asymptomatic patients. Accordingly, every effort should be made to histologically confirm the diagnosis of Epstein-Barr virus or post-transplantation lymphoproliferative disorders. Occult sites of post-transplantation lymphoproliferative disorders are assessed by computed tomography of chest and abdomen. More recently, increasing interest has focused on the potential role of positron emission tomography, abbreviated as PET, scans as an alternative or supplemental imaging modality in the diagnostic evaluation of patients thought to have Epstein-Barr virus disease and/or post-transplantation lymphoproliferative disorders. Palpable nodes or lesions, or both, identified by radiographic surveillance should be sampled. Endoscopic evaluation should be considered in patients with diarrheal illnesses and elevated viral loads. Histologic evaluation for typical features may be augmented through the use of the Epstein-Barr encoded RNA, abbreviated as EBA, probe. The use of the Epstein-Barr encoded RNA probe may be particularly useful in differentiating between the presence of rejection and Epstein-Barr virus infection among intestinal transplant recipients. Management of patients with post-transplantation lymphoproliferative disorders is controversial. Reduction of immunosuppression is recommended widely. Antiviral agents typically are used, although their role has not been studied formally. Reduction of immunosuppression, alone or in combination with antiviral agents, results in an approximate 67% cure rate of Epstein-Barr virus disease and post-transplantation lymphoproliferative disorders. The potential impact of monoclonal antibodies, interferon, and chemotherapy awaits formal clinical trials. Resection of tumor also may be of value for patients with lymphoma. Recent experience has focused on several novel approaches to the management of Epstein-Barr virus disease and post-transplantation lymphoproliferative disorders. These newer strategies have typically been used for patients who fail to respond to reduction of immune suppression, with or without the use of antiviral agents. Rituximab, an anti-CD20 antibody, has been increasingly used for the treatment of Epstein-Barr virus disease. Experience to date suggests that as many as 2/3 of patients who fail initial withdrawal of immunosuppression will respond to a 4-week course of this agent. However, relapse of Epstein-Barr virus disease has been observed in 20% to 25% of treated patients 6 to 8 months after completion of therapy at the time the rituximab is no longer present in the body. An alternate chemotherapy-based approach for patients who fail to respond to initial reduction or withdrawal of immunosuppression has also been proposed. This strategy, which uses modified doses of cyclophosphamide and prednisone, has also achieved success in approximately 2/3 of treated patients. Unfortunately, as with rituximab, Relapse of post-transplantation lymphoproliferative disorders has been seen in 22% of treated patients, and outright treatment failures have occurred in patients presenting with fulminant disease. Definitive studies comparing these two second-line therapies are needed to define the best option for those children who fail to respond to initial therapeutic modification of immunosuppression. A summary of our suggested approach and management of Epstein-Barr virus post-transplantation lymphoproliferative disorders is provided in Table 72.5. Pause the video and carefully scrutinize Table 72.5 summarizing an overview of diagnosis and management of viral infections after liver and intestinal transplantation in children before advancing to the next slide. We will now discuss other herpes viruses. Other herpes viruses can also be hazardous after transplantation. Herpes simplex virus, abbreviated as HSV, can reactivate early after surgery or after augmentation of immunosuppression. Prophylaxis with acyclovir, or ganciclovir, has been beneficial in these situations. A summary of the suggested approach to the diagnosis and management of herpes simplex virus is provided in Table 72.5. Primary varicella infection, also called chickenpox, in transplant recipients can lead to disseminated, fatal disease and should be treated early and aggressively with intravenous acyclovir. Some centers have used valacyclovir rather than intravenous medication, but further studies are needed. Reactivation disease as shingles is more commonly seen in adults and can be prevented with antiviral prophylaxis early in the transplant period. Valacyclovir can be used for treatment if shingles is mild, but if severe or disseminated, then intravenous acyclovir use is prudent. Interest has also focused on determining what role, if any, human herpes virus 6, abbreviated as HHV6, and human herpes virus 7, abbreviated as HHV7, may play in causing disease in organ transplant recipients in general and abdominal transplant recipients in particular. Several groups of investigators have identified a potential interaction between the development of human herpes virus 6 and human herpes virus 7 and cytomegalovirus infection in organ transplant recipients. Reactivation of human herpes virus 6 infection after liver transplantation has been associated with the development of an increased cytomegalovirus viral load in the peripheral blood as well as a greater likelihood of developing symptomatic cytomegalovirus disease. In addition, it has been suggested that some or all of the symptoms typically associated with the cytomegalovirus syndrome, e.g., fever, leukopenia, in patients with proven cytomegalovirus infection may be attributable in part to human herpes virus 6 or human herpes virus 7. Studies in children have suggested that infection due to human herpes virus 6 alone is a relatively common cause of unexplained fever in pediatric liver transplant recipients. Interest also exists in the role, if any, that human herpes virus 8, abbreviated as HHV8, may have in causing infection and disease in organ transplant recipients. This is particularly true for recipients who come from countries with moderate to high rates of human herpes virus 8 prevalence such as Africa, the Middle East, and the Caribbean. The full spectrum of disease of these more recently recognized herpes viruses and their potential therapies remain to be determined. We will now discuss adenovirus. Adenovirus has been reported to be the third most important virus affecting pediatric liver transplant recipients, occurring in 10% of one series of 484 children undergoing liver transplantation under cyclosporine-based immunosuppression. Symptomatic disease. ranging from self-limited fever, gastroenteritis, or cystitis to devastating illness with necrotizing hepatitis or pneumonia, occurred in more than 60% of infected patients. Infection was most commonly diagnosed within the first 3 months after transplantation. The frequency of invasive adenovirus infection after pediatric liver transplantation appears to have decreased markedly with the use of tacrolimus-based immunosuppression. In the tacrolimus era, McLaughlin and colleagues found that only 4.2% of pediatric liver recipients experienced adenovirus disease. This is in contrast to a significantly higher incidence of 20.8% of adenovirus infection in pediatric intestinal transplant recipients at the same institution. A high rate of adenovirus infection after pediatric intestinal transplantation was also reported by Florescu and colleagues, who noted that 39% of their cohort was infected, with 60% of infected patients recognized as having adenovirus-attributed disease. Finally, Pinchoff and colleagues found adenovirus in all 14 of their pediatric intestinal transplant recipients. However, these exceptionally high rates might be attributable to the fact that viral cultures and PCRs were performed as part of routine screening of graft biopsies, and not all of the patients were symptomatic. When symptomatic, high stool output, alone or in the presence of fever, was the most common sign found. It is difficult to presumptively diagnose infection due to adenovirus in pediatric abdominal transplant recipients because fever, hepatitis, and pneumonia may be caused by a variety of other pathogens, and high stool output after intestinal transplantation is nonspecific and can also occur with rejection. The presence of high-grade fevers and symptoms suggestive of adenovirus infection should prompt serial cultures for viruses, including adenovirus, or PCR investigation and evaluation of graft biopsies. Unexplained elevations in hepatocellular enzymes suggestive of hepatitis should warrant consideration of a liver biopsy. Similarly, an increase in stool output, with or without fever, should prompt endoscopic evaluation of the intestinal allograft. Histologic examination for the presence of adenoviral inclusions as well as the use of immunohistochemical stains of biopsies specimens from either site should be undertaken to help confirm this diagnosis. Definitive evidence evaluating potential treatments for adenoviral disease is not available at this time. The most important component of therapy is supportive care along with a decrease in immunosuppression. The role of antiviral agents is unproved, but increasing data support the use of C-dofovir in bone marrow or solid organ transplant recipients. Current available guidelines support consideration of use of this agent for patients with proven disease. Ongoing studies are investigating the potential role of brincidofovir, a lipid ester of C-dofovir, which is currently in trial in bone marrow transplant recipients. This drug, which is orally bioavailable, has been associated with less nephrotoxicity and may actually be more potent than the parent compound. Finally, a single case report also raised the possible role of intravenous immunoglobulin as treatment for adenovirus infection. A summary of a suggested approach to the diagnosis and management of adenovirus infection is provided in Table 72.5. We will now look at common community-acquired viruses. Although the course of illness has been poorly documented, most children who undergo liver and intestinal transplantation experience the usual respiratory viruses and gastrointestinal illness without significant problems. However, infections due to influenza virus, parainfluenza virus, or RSV led to more severe disease in young children, especially if infection occurs soon after transplant and/or during periods of maximal immunosuppression. Likewise, transplant recipients may have prolonged viral shedding even after resolution of symptoms. A summary of suggested strategies for the diagnosis and management of these community-acquired viruses can be found in Table 72.5. And now we will focus on other viruses. Other viruses, including both donor-associated viral infections, e.g., hepatitis B and hepatitis C virus, as well as community-acquired viral pathogens, e.g., rotavirus, norovirus, or arboviruses, are relatively uncommon causes of clinically significant infection or disease after abdominal transplantation. Although this may be explained in part by the paucity of data describing infectious complications late after transplant, severe infection owing to these agents appears uncommon. For those patients for whom infection due to these pathogens is recognized, consultation with the primary transplant center is strongly recommended. Suggested approaches to the diagnosis and management of each of these viral pathogens are provided in Table 72.5. We will now discuss opportunistic infections. Pneumocystis jirovecii is a well-documented cause of pneumonia in immunocompromised patients, including liver and intestinal transplant recipients. Prophylactic trimethoprim sulfamethoxazole is safe, inexpensive, and effective. The use of this strategy has eliminated pneumocystis jirovecii pneumonia in these patients at CHP, with rare breakthroughs occurring in patients who discontinued prophylaxis. Alternative prophylactic regimens for the sulfur-allergic patient include aerosolized pentamidine, for patients above 5 years of age, atovaquone or dapsone. Tuberculosis is a particular concern in immunosuppressed hosts, including recipients of liver and intestinal transplantation. The incidence of TB after liver transplantation in Europe and the United States has been reported to range from 0.9% to 2.3%, with most reported cases in adults. In contrast, up to 15% of organ transplant recipients in areas of high-level endemicity may develop TB. However, development of TB after pediatric liver transplantation is uncommon, with less than 20 cases reported. To date, no cases have been reported among recipients of intestinal transplantation. Development of TB among solid organ transplant recipients is associated with mortality rates ranging from 25% to 40%. With additional morbidity and mortality associated with development of rejection in patients receiving anti-TB therapy. Diagnosis of TB in transplant recipients is complicated by the fact that extrapulmonary disease occurs frequently and purified protein derivative, abbreviated as PPD, testing is likely to be unreliable after transplant. Management of TB in liver transplant recipients is difficult both because of the side effects of anti-TB agents and the potential interactions with immunosuppressive agents. Limited published experience in pediatric liver transplant recipients suggests that the majority of infections due to Mycobacterium tuberculosis are most likely due to a primary infection, often associated with family contacts who have positive skin tests. In contrast, experience with adult transplant recipients suggests that development of TB is more likely due to reactivation of latent TB. Although only limited published information is available describing TB in these patients, transplant recipients known to have a positive PPD or who come from an area endemic for TB appear to be at increased risk for symptomatic reactivation after transplantation. Similar data are not available for recipients of intestinal transplantation. Additional factors predisposing to the development of TB after transplantation include severe hepatic failure at the time of transplant, aggressive anti-rejection therapy, and/or concurrent HIV infection. Experience among adult renal transplant recipients suggests that although the risk appears greatest in patients who received inadequate or no prior TB therapy, it can also occur in patients who received appropriate anti-TB therapy in the pre-transplant period. Although TB has only rarely been encountered among pediatric liver transplant recipients, and not among intestinal recipients, screening for TB by history and a PPD test or interferon gamma release assay, abbreviated as IGRA, along with review of a chest radiograph for lesions consistent with healed TB, is highly recommended. However, the use of interferon gamma release assays for even immune-competent children younger than 5 years of age is not recommended at this time. Patients with a positive TB history and/or a positive screening test, either PPD or interferon gamma release assay result, should receive isoniazid for 6 to 12 months after transplant, although some experts recommend continuing this agent indefinitely while patients remain on immunosuppression. Attempts at a more definitive diagnosis are indicated for patients from endemic areas with a negative PPD result but suggestive chest radiograph. Careful evaluation for evidence of side effects, particularly hepatotoxicity, is recommended, and isoniazid is discontinued if unacceptable toxicity is identified. Additional potential opportunistic infections include cryptococcosis, coccidioidomycosis, and histoplasmosis, although the pathogens of these infections have not been frequently reported among pediatric liver or intestinal transplant recipients. Prior infection with these pathogens is common in geographic areas where they are endemic. Because patients often travel to transplant centers distant to their homes, it is imperative that transplant physicians be aware of the local environmental risks for each patient. Experience with coccidioidomycosis in transplant recipients suggests that a minimum of 4 months of antifungal therapy, such as fluconazole, should be given in transplant recipients with this history. Similarities between coccidioidomycosis and other fungal pathogens suggest that similar strategies may be necessary for patients with a positive history of prior fungal infection with pathogens known to recur after resolution of primary infection. We will now discuss management. Let's begin with pre-transplant evaluation. A pre-transplant evaluation is helpful in the management of infectious complications in liver and intestinal transplant recipients. A complete history and physical examination should be performed with particular attention paid to previous infections, immunizations, and drug allergies. Attention should be paid to a history of infection with MDR bacteria, which may provide guidance for future empirical treatment that may be required after transplantation. An intermediate-strength tuberculin skin test or an IGRA for children older than 5 years of age should be performed on all patients. The CHP pre-transplant protocol includes obtaining serology for CMV, EBV, varicella, herpes simplex virus, hepatitis A, B, surface antibody, surface antigen, and core antibody, and C, and HIV for all candidates. In addition, serology to measles, mumps, and rubella is obtained to ensure that the patients have a measurable antibody response to prior immunizations. Serologic tests on the donor should include HIV, hepatitis B and C, CMV, and EBV. Donors positive for HIV should be excluded, with the rare exception of approved research protocols in the United States as prescribed under the HOPE Act. The use of organs from donors who test positive for hepatitis B or C virus would typically be contraindicated except in the circumstance in which the recipient is also positive for hepatitis B or C, respectively. Knowledge of donor and recipient status for these viruses allows one to anticipate infection, identifying patients who might benefit from prophylactic regimens and guiding in the diagnostic evaluation of fever. We will now discuss prophylactic regimens. Prophylactic regimens vary among transplant centers. These strategies have been divided into perioperative and long-term prophylaxis and often evolve to reflect the infectious complications seen at individual institutions. Perioperative prophylaxis is used to prevent intraoperative sepsis and wound infection. It is based on individual patient characteristics and expected normal flora. At CHP, piperacillin tazobactam is used as the standard agent for perioperative prophylaxis. This is modified if the recipient is known to harbor antimicrobial-resistant bacteria. If sepsis is suspected in the donor, antibiotics are chosen to cover those organisms identified from the donor, and treatment is usually extended to a therapeutic course of 10 to 14 days. In the absence of proved or suspected infection in the donor, perioperative prophylaxis is usually limited to the first 48 hours after transplant. Considerations regarding long-term prophylaxis against infections occurring beyond the perioperative period include the risk and severity of infection as well as the toxicity, cost, and efficacy of a given prophylactic strategy. Nystatin is recommended for all pediatric transplant recipients in an effort to prevent oropharyngeal candidiasis until the patients are on less than 5 mg per day of prednisone. Trimethoprim sulfamethoxazole is used to prevent pneumocystis jirovecii pneumonia. Although some centers recommend using trimethoprim sulfamethoxazole for only the first 6 months after liver transplantation, anecdotal experience with patients presenting with PCP long after transplant and the relative safety of this agent have led us to recommend its use indefinitely after liver and intestinal transplantation in children. The frequency and severity of CMV infection in transplant recipients prompts consideration of prophylactic strategies. Optimizing the target population and timing of interventions requires further study. Current guidelines primarily focus on 2 approaches to the prevention of CMV: chemoprophylaxis, where all, at risk, recipients receive antiviral therapy for a defined period, and surveillance monitoring of CMV load in blood, most commonly using NAT, in those deemed to be at risk to inform preemptive initiation of antiviral therapy. Data on use of monitoring and preemptive therapy after pediatric transplantation remains sparse, although sequential use of shorter courses of prophylaxis followed by monitoring, also called hybrid method, has been employed and is currently favored by many pediatric transplant centers. Whichever CMV prevention strategy is chosen, potential roles exist for intravenous and oral ganciclovir and oral valganciclovir as the antiviral agents for these strategies. Currently, CHP protocols use intravenous ganciclovir alone, for varying durations, for liver and low-risk intestinal transplant recipients, recipient CMV positive before transplant or donor and recipient seronegative, and ganciclovir plus intravenously administered immune globulin containing a high titer of antibody against CMV for high-risk, donor CMV positive and recipient CMV negative, intestinal transplant recipients if available. As noted earlier, at CHP, we now include sequential monitoring to inform the need for a secondary course of antiviral therapy after completion of an initial course of antiviral chemoprophylaxis. At present, The use of oral valganciclovir is an alternative to prophylaxis with intravenous ganciclovir for adolescents, although the use of this medication is not approved for liver transplant recipients, because a higher rate of tissue-invasive disease was observed in liver transplant recipients receiving valganciclovir compared with oral ganciclovir in the pivotal trial evaluating this agent. Nonetheless, published guidelines support the use of valganciclovir for adult liver transplant recipients. Pharmacokinetic studies for dosing oral valganciclovir suspension in children after transplantation adjusted for body surface area and renal function suggest that ganciclovir exposures similar to those established as safe and effective in adults can be achieved. Similar to CMV, there is an interest in the prevention of EBV infections and post-transplantation lymphoproliferative disorders. A number of different strategies are used, including immunoprophylaxis, viral load monitoring, and preemptive therapy. The efficacy of these approaches has not been established. The use of viral load monitoring to inform preemptive reductions in immunosuppression appears to be the most promising of these strategies. Because reduction of immune suppression is not always possible for intestinal transplant recipients with a rising EBV load, preemptive intravenous ganciclovir and intravenous immune globulin have been used in addition to reduction of immune suppression, where possible, for this cohort of patients. Although prospective comparative data are not available, the use of this strategy appears to have resulted in decreased risk for disease and improved outcome compared with historical controls who were not followed with this strategy. The use of anti-CD20 monoclonal therapy has also been used by some centers when decreased immunosuppression is not possible. And now, in conclusion, infections remain an important problem after liver and intestinal transplantation. Knowledge of the type, timing, and predisposing risk factors for these infectious complications allows for their timely and appropriate diagnosis and management. Thank you.